So I think maybe we'll start again, and I don't know if there are some people hanging out in the hallway there, but if they hear everything quiet down here, they'll probably trickle back in. So I'll take my time starting. Thanks. So I have two more talks. One is now, and then one tomorrow, and both of them are really going to focus on aspects of therapy and treatment. And this morning's talk is going to really focus on things that I think are very important and can oftentimes have a much greater effect than some of the fancy things that are being looked at in laboratories across the world, and some of the high-level molecular and genetic and epigenetic interactions that people are looking at are all fabulous and great for life sciences and remarkably interesting. But there are huge things that we can do just by maintaining physiologic status that can really have robust changes in outcome. And hypothermia is actually one of those examples where a relatively simple approach can have dramatic effects on overall outcome. So the topic of this afternoon, or this morning I should say, sorry, is therapeutic approaches to perinatal brain injury, and simplicity is the mother of intervention. So many of you know simplicity is the mother of invention. This is the mother of intervention. And so what I'm going to talk about is really review what the contributors are to perinatal brain injury. And you've had a little bit of this already, so I won't take a long time, and discuss why they occur and some really simple approaches that are very doable, and many of you are probably already doing in terms of improving outcome. But really to emphasize how important they are and how important it is to be diligent about them. Because I know in our hospital, and not just in our nurseries, but on our wards as well, we sometimes overlook simple things like monitoring a blood pressure or making sure that glucose values are okay, or treating with iron when there's iron deficiency, because we don't see those as being highly scientific, but in fact they are. So anyway, you'll recognize this because I showed it yesterday, and the next two slides are really just trying to remind you that obviously there's a very complex cascade of events that happens that results in cell death. But each of these aspects has an effect on physiologic parameters and are important to look at. And the other is that perinatal brain injury is complex. So when we look at a complex system, we often think of complex solutions. But there are many things, there are oftentimes simple approaches to complex problems. And that's what I'm trying to get across to you this morning. And hopefully I'll be able to do that. And the reason I say that is, like hypothermia, it's important to sort of look at the larger picture, trying to prevent perinatal ventricular or PVL by simply attacking one of these aspects is going to be very, very challenging, because the body has an amazing way of getting around all of this. If we interrupt the inflammatory response, it's going to go to free radical production or membrane injury or calcium metabolism or increased glutamate. Whoever made this system was pretty smart about finding trapdoors to get us caught. So we're much better off looking at the high-level things and trying to interrupt or prevent some of these aspects than we are at trying to find the silver bullet. So we all know that there are many complications to prematurity and hypoxic ischemic encephalopathy, and some of them are thermoregulation. We've talked a lot about that this morning. I'll speak a little bit more. Seizures, hypoglycemia, hypo or hypercapnia, humidity control, in infection and sepsis. And again, if the only thing you walk out with is that there are some simple approaches that you should pay attention to, then I'll be a happy guy. Let's just take this case scenario, which I'm sure many of you have seen many times before. Is a late preterm infant with spontaneous rupture of membranes. Baby has meconium and meconium aspiration, or meconium with the rupture of membranes, variable decelerations, decreased fetal heart rate variability, and then suddenly gets a deep, prolonged fetal heart rate deceleration for about 7 minutes, and somebody undertakes a cesarean section. So we all know that this baby is going to come out depressed, probably with low APGAR scores, probably acidotic, and likely having seizures, and with an MRI scan that shows both basal ganglia and diffuse ischemic injury. And babies like this are going to come out with poor temperature control and temperature regulation. They're either going to be hypothermic. If you don't actually put them under a radiant heater, they're going to become hypothermic. Or if they develop seizures, as I showed you earlier on, they're going to become hyperthermic. And if your nursery is anything like ours, we actually don't really pay a lot of attention to hyperthermia because we're so focused on hypothermia now that we don't really pay a lot of attention to hyperthermia. And maybe this is becoming secondary, but it's important. So what I wanted to show you in this particular slide is a bit of a remake of what we showed you before, or last time, but to emphasize that in the babies who were actually cool before they underwent injury, they actually had a much higher mortality rate than the babies than the newborn rat pups who were normothermic, or even those who were hyperthermic. So it's important, like I said, in terms of timing, to know when you're going to induce hypothermia. And particularly in preterm infants who have multiple episodes of apnea or bradycardia, not so much in the term babies who have an intrapartum event, but in babies who are already in your nursery, who are premature, have repetitive episodes, do we really want to cool them? And those studies, as was alluded to by Peter and myself earlier, are not yet done. So just translating what we know about hypothermia in the term and near term infant to a preterm infant with multiple episodes, I think might be a bit dangerous. So we have to be careful about that, and at least in our experiments, it actually caused more harm than good. So that's something we can easily control for and be cognizant of. We know that this baby is going to have seizures, and what does that mean? So again, knowing that seizures causes hyperthermia, an increase in temperature, will changing that make a difference? In other words, will cooling them or treating the seizures make a difference? And when we looked at our neonatal seizures, what we found, there we go. What we found when we induced the seizures in our newborn rat pups, we saw tremendous damage within the hippocampal region here, and this is shown with a GFAP stain. So for astrocytes, and this is just a H&E stain. So these very bright pink areas are damaged cells within the hippocampus. When we cooled these babies, what we found was that the amount of damage that we saw was dramatically less in both H&E staining and with GFAP staining. So the response, the inflammatory response was markedly reduced, and the cell death response was markedly reduced. And we can see that just in graphic form there. Now, why do we think that happens? We're not entirely sure, but when we do know that when you have a hypoxic ischemic event, we get a big drop in, these are blood glucose concentrations in the blood of these newborn rat pups. We know we get a dramatic drop in their blood glucose concentrations, and during recovery, we see recovery of blood glucose. But in those animals where we saw more damage with the seizures, we actually saw no recovery of their blood glucose concentrations. And why does that happen? Why don't these animals get a recovery, and presumably humans get a recovery to their blood glucose concentrations? Probably because they're in a hypermetabolic state. So you have a brain that is already depleted of energy and is fighting to get its energy back. And in order to get energy back, it needs reperfusion of blood, it needs sugar, and it needs oxygen. If you then put an already compromised brain basically into a seizure, which is a hypermetabolic state, in other words, it requires lots of energy and lots of sugar to sustain a seizure, then you're going to compromise that brain even further, because the supply of sugar and or oxygen to an overly active brain will outstrip the demand. The demand will outstrip the supply. So once you place an already compromised brain in a further compromise, you're going to get increased damage, and we see that here because when we cause seizures in those brains that were damaged, when we get a hypoxic ischemic insult, their energy is depleted. In those brains where there's no further damage, they have recovery of their energy. In those brains where there is further damage, there's significantly less recovery of their energy. And we think that that's probably due to an inadequate supply of substrate, which under these circumstances would be glucose. So it may be worthwhile actually enhancing their glucose concentrations during recovery from a seizure or during a seizure so that they have enough substrate. There have been some studies done by Vannucci's group quite a while ago where they did this similar kind of work, and they gave the seizuring animals extra glucose, and it actually reduce the amount of injury that we saw. I'm just going to skip over that. When we look at those animals who are seizuring, what we also see here is that during the hypoxic ischemic insult, they have a massive increase in their glutamate, that neurotoxin that causes damage when it accumulates in the cells. And then when the seizures happen, and they cause damage, we see that happen again. So there's hypoxia ischemia, recovery, and seizure, and then a massive increase in their glutamate concentrations as well. And those are dampened when they're placed in hypothermic circumstances. So this line flattens out, and the amount of damage is less. So I'll just jump over those. So should we be treating neonatal seizures clinically or otherwise? My answer is actually yes, because there's been, frankly, a lot of controversy about do we treat neonatal seizures or don't we? Do they cause damage or don't they? And this experiment that we did in our lab and now has been confirmed by several other labs and clinically as well has really changed my focus around. So we quite aggressively treat our seizures, whether they occur with hypothermia or not. And I think one of the big questions that we were just talking about earlier is whether or not we should be treating our babies prophylactically. In other words, giving them some kind of anticonvulsant beforehand, before they get seizures, in order to presumably obviate that effect. So the other things that happen to these babies are physiologically are changes in their glucose concentrations. This is another area that's still really quite controversial. Does hypoglycemia cause brain injury? And I'm not entirely sure about the answer, but again, some of the preclinical work we've done in our animal studies has really changed my mind. So this is an MRI scan of a baby who presumably has had a hypoglycemic event. There are some pretty characteristic features here. There's presumably white matter injury in the posterior regions and predominantly the occipital lobes, and in some cases the anterior regions as well. And this has been fairly well published in the literature on the clinical side of things. What is unclear is whether or not this kind of result can occur as because of pure hypoglycemia. In other words, hypoglycemia alone without anything else. And I'm not sure that question has been entirely answered, but I'll give you some clues to that. So this is some work done by Steve Miller and their group. And they showed that hypoglycemia was in fact relevant, that it did cause damage, but it didn't do so in the absence of other injury. In other words, a good percentage of these children had low pHs or significantly lower pHs than the group of children or group of babies that didn't have hypoglycemia. And they also had seizures and encephalopathy. So based on this study, which is a pretty good study, it still doesn't answer the question as to whether or not hypoglycemia in and of itself will cause brain injury. What this does tell me is that when you put hypoglycemia on top of an already compromised brain, so I already showed you animal data that suggested that if a baby's undergone hypoxia ischemia and then seizures, it may actually, low blood sugar may be at the heart of some of that injury. This is confirming that from a clinical perspective. He's telling us that if you have seizures or an encephalopathy or a low pH, when you add hypoglycemia on top of that, that's not a good thing. And clinically, when you look back at the data that Kornbluth did a long time ago in the, I think, 80s and perhaps even 70s, that question was still out there. So 30 years ago, we were asking that question. Today, we're still asking that question, and I don't think it's entirely answered unless somebody knows something that I don't, which is possible. But he looked at it, and what they determined after doing a lot of retrospective study, a lot of retrospective work, was that basically if you have hypoglycemia in the absence of anything else, so just hypoglycemia, you're more likely to get damage if it's prolonged, if it recurs over a period of days, and if it's severe. So outcomes are poor if it occurs repetitively over 5 days, and that makes sense. So we decided to look at this in a bunch of rats, and this is just a slide to emphasize how much work we did. It was a damn lot of work. We looked at many newborn rats and injected insulin over actually a period of 3 days to achieve mild, moderate, and severe hypoglycemia, and we did all that. And then we did behavioral assessments on all of those groups of rats. And this is behavioral data, but obviously what you can see here is that I don't have any stars, I don't have any red, I don't have any p-values, because it actually made no difference to the overall behavioral data of our animals. And this is pure hypoglycemia, it's not on top of anything else. But when we looked pathologically at these animals, we did find some interesting changes. This is just control. This is something called a fluorojade stain. So things that die turn bright, bright green. And so this is a normal control. We're not seeing any cell death, which is what we'd expect. But these are severe hypoglycemic animals. So these are animals that underwent hypoglycemia for a period of longer than 12 hours, with a glucose concentration of less than 1 millimole, so quite significant. And all we saw was this area on the majority of our animals that showed some cell death. And this is actually the reticular activating nucleus. So what does this mean? I don't really know what this means in the long run because we didn't see any behavioral abnormalities, but what it suggests to me is that if you have severe hypoglycemia for a lengthy period of time, it's not benign, even without anything else on top of it, and we should be aggressively treating those children. And because it involves the reticular activating system, even in a rat, maybe this abnormality heralds things like attention deficit disorder in the future or other aspects. And we looked at some excitatory amino acids and their profile, and we found an increase in aspartate and a decrease in glutamate and an alanine. The aspartate, again, being one of the neurotoxins that accumulates during cell death. So what I determined from all of that is, if we look at a brain that's already been compromised with hypoxia ischemia or seizures, treating glucose concentrations aggressively, in my opinion, is very important. It's something that we can easily do, something we can monitor quite easily. And the old adage of too high glucose doesn't really apply to newborns in the same way that it does to adults. And very low glucose concentrations for a sustained period of time is also not good and certainly not benign. So we need to pay attention to that. So this is another case, just PPROM at 28 weeks, early labor and contractions, trying to interfere with labor and delivery was not effective. The male baby was born prematurely, so already we know he's got a problem because it's a he. Baby's intubated and ventilated, receives surfactant therapy, and undergoes a number of different complications, one of which is hypocapnia and or hyperoxia. And again, do those things contribute to injury? So we've heard a little bit from some of our colleagues in the audience that hyperoxia is not a good thing. And in fact, when we look at that individually or in combination with low concentrations of carbon dioxide, we do see that the relative outcomes, this is a clinical study, is significantly worse than if either hyperoxia or hypercapnia were not part of the picture. When people have looked at this in animal work or in vivo data, again, these are normal controls. This is a hippocampus in a rat. Under hyperoxia conditions, there's a significant cell death, and the amount of oxygen-free radicals is markedly increased under hyperoxic circumstances. So what was alluded to by Peter early on, and what we used to do in our nursery routinely when I was younger, was use 100% oxygen all the time, and we'd hyperventilate these poor babies up the wazoo. And clearly we were not doing a good thing, even though we thought we're not. So moderation in both of those aspects, and probably maintaining as close to normoxia as one can, or certainly not significant hyperoxia is a good idea. And again, keeping within normal carbon dioxide levels is probably a good idea. Should we be using hypercapnia? In other words, should we be giving a bit of carbon dioxide to these babies or almost underventilating them? And that's a question that hasn't been entirely answered. But in animal studies or in preclinical studies, this is work done by Bob Vanucci, and he looked at our 7-day-old rats. This is just a damage score. The higher the number, the worse the damage. And these are just the number of animals. So if we look at the typical way this experiment is run, which is with zero carbon dioxide, then what we see is that the damage score is pretty much even. When we add carbon dioxide to this regime, what we find is that the damage is actually shifted to the left. In other words, there's less damage in more of the animals than under no carbon dioxide circumstances. And when Pappas looked at this in the clinical data, trying to correlate how long babies were hypercapnic under circumstances of ventilation, he found that the rate of disability and death was greater under circumstances where the carbon dioxide was low, where they were in environments of low carbon dioxide compared to higher carbon dioxide. So there probably is something to this story. I think some of the more refined aspects are not really quite known. But what I think the message, at least to me, is that too much of anything is probably not a great thing. Too much oxygen is definitely a bad thing. And in terms of carbon dioxide, too little carbon dioxide or hyperventilating these babies is also not a good thing. And it's entirely possible that keeping them mildly hypercarbic may actually have some benefit. And I think the question is still out as to whether or how we actually approach that issue from a clinical or preclinical perspective. So this is something that I came up with a little while ago, and that's humidity. And the reason this intrigued me was because I was walking through our intensive care nursery where a bunch of premature babies were, and I was trying to look through the incubator, and it was like a rainforest in there because there was so much humidity that it actually was literally raining inside the incubator. It was about 90% humidity. And I asked our neonatologists, what's up? And they told me, and this makes sense, that, obviously keeping babies in a relative, or especially small for gestational age or premature babies in a high humidity was useful to prevent insensible water losses, etc. And that's the whole concept around wrapping babies in plastic bags or saran wrap, or however some of you may do it, or keep high humidity incubators. So I thought, well, that's odd, because aren't we using hypothermia to try and treat babies? And certainly when you have high humidity, isn't that a higher temperature? So we did a simple study where we adjusted the humidity with our baby rats under hypoxic ischemic circumstances to figure out whether or not that would be that would have a negative effect on their outcome. So this is just a amount of damage over here. The higher the number, the worse the damage. And this is a humidity level. Low was about 30%, mid was 60%, and high was 90%. And what we determined here was that under conditions of low humidity, which would be probably here and in the prairies compared to the coast in Amsterdam, for example, or in Vancouver, the babies actually did better, and their brain damage was better. And I thought, well, that makes sense, because there's probably just a change in temperature, and high humidity comes associated with high temperature, so that must be the problem. But then we tried to correct for that. And what we did was we looked at two other groups where we maintained the humidity low, but kept the temperature high in the 39-degree range, and where we kept the temperature, the humidity high, but the temperature low. So that kind of reversed the effects and presumably normalized whether or not temperature would have an effect on the overall outcome. And lo and behold, under these circumstances, the babies who were under low humidity, even if their temperature was high, did way better than the children who had high humidity but low temperature. So what that told me was that humidity in and of itself actually has an effect which is slightly different than or separate from temperature. I don't know what that might be, but it's a message to me that, again, we need to be conscious of the environment that we put these babies in. And in our nursery, except within the humidity is just free, it's whatever the hospital decides the humidity in the hospital is going to be. In the nursery, we can adjust for that either within the incubator, but if they're in an open air bed or if you're wrapping them, it's just something to be cognizant of, and certainly watching their temperature and ensuring that humidity doesn't get too high is probably an important thing to be cognizant of. So we all know that infection, and we've all heard a lot about infection, and those are things that we can look at and be cognizant about and presumably treat. We know that an inflammatory response now can last for not only hours but probably weeks, and under these circumstances this group showed that it was actually lasting for months, so that's a very long time. We know that the risk for cerebral palsy is much higher with a fetal inflammatory response and chorioamnionitis, and it differs based on whether or not you have clinical chorioamnionitis or just biochemical chorioamnionitis, and the risk increases at each step of those, and the risk can be as high as 3 to 4 times as great. And this has been looked at now by, again, Steve Miller group with Hannah Glass and Emily Tam. And what they found is in their premature group, if they looked at multiple infections, there was certainly a much higher risk of cerebral palsy than in those that didn't. And they also found that under circumstances where there was either clinical infection, or positive cultures, there was also much higher risk. And that was kind of exponential. In other words, if you just had clinical signs, there was an increased risk, but if you also had positive culture positivity, your risk was even significantly higher. And that's been shown on numerous occasions with preclinical animal models. This is a study that was done by Guillaume Sabir in Montreal, and this is actually an MRI scan of rat with multiple gestations, and what you can see here is, if I can point this out, so each of these is a baby, because rats or rodents have usually about anywhere between 10 and 16 fetuses in their uterine horns, and when he gave LPS, these became dark, which meant that the placenta was really the blood flow was interfered with during LPS treatment. And we looked at the same thing, and then we looked at behavior after. So with LPS, this is just a representation of behavior and infection. One of the developmental reflexes in rats was significantly delayed compared to controls, and this is some work we did with natural health products and found that it improved, and I'll talk a bit more about this later. Pierre Grassans has done a lot of work also with an LPS model, and you can see here that if you look at the corpus callosum, there's significantly less myelin basic protein, which is the marker for white matter. And with LPS, you get significantly less production of that, which means that your white matter is diminished, which is really the anatomical substrate for cerebral palsy. And if people look at adding infection to a hypoxic ischemic insult, it's much more severe. But if you actually treat the infection, in this case it's with minocycline, you get marked improvement in overall pathology and behavioral outcome. So again, and that's shown both with minocycline and DoxyCycline, and others have shown it with other antibiotics as well. If you treat the infection, you get a marked improvement in the overall brain damage compared to not treating the infection. This is work done by Catherine Todd at the University of Alberta as well. So again, it leads to the question as to whether or not we should really prophylactically treat some of these babies or not, but certainly if there's any evidence of clinical infection or any evidence of biochemical evidence or clinical evidence or positive cultures, we obviously need to be on top of that very quickly. So this is a fairly short talk, but I just want to emphasize that there really are some simple things that we can do that in my mind will dramatically improve outcome in all of our nurseries. They're not sophisticated. They just mean that you have to be diligent and cognizant of the physiologic parameters and try and maintain physiologic homeostasis in these babies. So strict temperature control, being aggressive with seizures, and in my mind being quite aggressive with glucose concentrations, and under the right circumstances even overshooting a little bit, ensuring that our oxygen concentrations are not too high and that our carbon dioxide concentrations are not too low, being mindful of what the humidity is within your incubators and within the setting of your hospital, and being aggressive with infection. And most of you know that there's a lot of work now being done with the NIDCAP study in terms of just how the babies are being treated, and the amount of noise around and how often they're being handled has a dramatic effect on overall outcome as well. So there are many things that we can do. It's obviously a complex problem. I've said that many times. But having a simple approach to complex problems can make a difference, and we should be quite cognizant of that, and it will go a long way to improving outcome. So again, I'm going to end there. That was a relatively short talk. Probably good for you. And certainly I'll be happy to take any questions. And I don't know if you guys want to pop up here and have any questions for the group. Is that what we're going to think about before lunch? It's an early lunch, so. Do you guys have any questions about what happened this morning or any of the talks this morning or from the previous day? Yeah, sorry.
Minocycline is shown to be neuroprotective. So do you think in this study there was sort of a bias as minocycline itself is neuroprotective and not only treating the infection?
Well, minocycline is neuroprotective because it reduces the inflammatory response. So it may be a combination of those things, both being an antibiotic and treating the infection itself, and treating the inflammation. Now remember, these studies are done with LPS, which is really not an infection, it's a stimulant to inflammation. So one would presume that the effect that minocycline or DoxyCycline had under these circumstances was in fact as an anti-inflammatory. And one would be jumping a little bit to say that it's acting as an antibiotic under those circumstances. But I think one can make a link between infection and inflammation, and even if you're not, if you're treating either one or both of those things, the presumption is that you'll have a better outcome. What we don't know is how late along the course you can treat before you'll get improvement, and how aggressive we should be early on. I think there was somebody.
According to your research, could you tell us or explain us what level of humidity should we set up in our incubator first, and does it affect the uninjured brain at the same level as injured brain suffer from? Thank you.
Good question. I think being precise about that, I think that the best I can do is to say that it seems that lower humidity is much better than like very high humidity. So when we looked at 30%, 60%, and 90%, it was the low humidity that had the best outcome. And 30% is sort of an average kind of humidity level. So that would be my recommendation, quite honestly. I'm not aware of it having any effect on sort of a normal brain. We didn't see any when we looked at that. No, I don't think it is. These guys might want to argue with that.
Yep, yeah, I do. I think we've got to distinguish between rats and people.
Yeah, no, we don't. Actually, if you look, they look pretty much the same.
The rationale behind humidifying preterm babies' environment is to reduce the amount of fluid we have to give them, isn't it? And so the link there works in the opposite direction. Whenever people have compared high fluid regimes with low fluid regimes, that's intravenous usually, it's the low fluid regime that comes out on top in terms of important neonatal outcomes. So I think that's the rationale for using high humidity in very, very preterm infants. This is the first time I've heard this hypothesis, and it's a very interesting one, and I think it's worth looking at in the human situation, but I think it'd be very dangerous to go back and dry all your babies out. I think that might be the wrong message. But I'd be interested in what Andreas has to say.
Well, so just to clarify, we better stay here so we're between us. I'm not suggesting that you dry your babies out. So I think we're looking at sort of two different kind of concepts. One is their fluid resuscitation, which is what Peter's alluding to, and the other is an environmental humidity. And how the latter works is not entirely clear. So our rats were in low humidity were not dehydrated by any stretch of the imagination. They were just simply not in a high humidity environment, which may actually have an external effect on the brain and insensible water losses. So I think you need to look at both. One is maintaining good hydration and good electrolyte status, which is what I'm suggesting from maintaining normal physiologic parameters, and the other is what humidity levels we're using. So there are different approaches to that. You can maintain good hydration by maintaining intravenous fluids, but still maintain normal or humidity levels without very high ones. So that would be my argument for you, Peter.
I'd go along a little bit with Peter on humidity because I think we also have to distinguish between term and preterm infants. And when you were just telling us about the rainouts in the incubator, that's probably, and we come to that later today about humidity, that's probably a problem of air conditioning, because then the humidity in your incubator is probably much less as it's indicated at the readings, because you're losing humidity if you have rainout. Because the rainout indicates that the wall is cold.
Yeah.
And so the absolute humidity in your incubator might be different. So we're going to talk about absolute and relative humidity. We don't know what the effect is in your animals because you don't know about the absolute humidity there. And in preterm infants, I would be very, very careful to reduce humidity. And in the asphyxiated infants, we usually treat them in open cot units. So we have the ambient humidity there. So it's a complete different story, I'd say. There was a question up there.
Okay, one remark and a couple questions. The remark number one is that maybe you, as a scientist, you should write a novel, a new version of John Steinbeck's book of Mice and Men, to write down of rats and men. Yeah, and a couple of questions. What's your opinion regarding the use of other agents? There's some anecdotal experience, I think starting from Japan from 2002, on the use of magnesium sulfate in hypoxic babies. And the cocktail, for me, it's a couple of ingredients. I mean, are you aware of any, let's say, animal studies that used 2 or 3 agents that might exert a cumulative or synergistic effect on different levels? So can you explain that? And the last question, maybe we should use there is a subset of some specific babies, let's say with HIE and seizures. should we use, apart from cooling, topiramate or other agents, and just extract this group from other babies? Thank you.
Who are you asking? So to approach your last question first, because I forgot the first question already. Certainly the animal data suggests that a combination of hypothermia and perhaps some anticonvulsants may be effective. When people have looked clinically in a retrospective fashion, at least with phenobarb, and it showed that the last time it didn't pan out. But a lot of the animal data does not exactly jive with the human data, because the human data it's a mixed bag predominantly, right? The different units are treating children differently. They may receive their anticonvulsants at a different time, and oftentimes it's delayed. So anticonvulsants are not given at the time of birth, but rather sometime in the hours after life begins. Whereas in the animal data, you've got a very controlled environment. So I think what the animal data tells us is that there's opportunity there. And what we need to be cognizant of, and what we're starting to learn, I think, in terms of how we translate the information to the human, is that we need to be somewhat precise in how we do that. So if the timing, for example, of hypothermia is important. It's not just simply a matter of doing hypothermia. Probably the timing of using anticonvulsants in conjunction with hypothermia will also be important. And so that's how I would approach that, is that we have some preclinical information that suggests it can be helpful. And I think that we need to design a clinical study that adapts those parameters in a very precise fashion to determine whether or not it'll be effective in the human. And certainly at the NIH, and I'm sure in the European group, there's lots of thought about looking at that kind of combination, because anticonvulsants are used in babies, so it wouldn't be a huge leap to add it to hypothermia. With respect to, did you want to say anything about that? Or Peter?
No, you keep going.
Keep going?
You're doing well.
Yeah. With respect to sort of multiple medications, I think that's hugely on the horizon in terms of, particularly in addition to hypothermia. There's no question that people are looking at cocktails. Again, what we need to be clear about is the circumstances around which we do that. So in animal studies where it works, we're very precise. We reduce all the variables, and we use just what we want to use under the circumstances that we want to use them. And oftentimes it's single doses or immediately after the event. Or sometimes before the event. And one thing we should be aware of is a lot of the animal studies show that multiple medications are useful if they're given right after the event or even prior to the event. Whereas when they're trying to be translated into the human, they're obviously given after the event. And so we need to make sure we're talking about apples and apples. Do I think it may be beneficial? I do. But it'll have to be under the right circumstances and with the right type of injury. I'm not sure that severely injured babies will benefit very much from some of the things we're suggesting, because the injury is pretty significantly advanced by the time we see them in the nursery even. With respect to magnesium sulfate, the retrospective studies, especially in mums who've received magnesium sulfate for preeclampsia, have been very, very positive, I think. I do know, at least I think of one clinical trial that's starting to look at magnesium sulfate as in a more prospective fashion as opposed to retrospective fashion. And I do know that Steve Miller's found when he's broken down his MRI data in mums who've received magnesium versus those who haven't, they also see MRI improvement or in the babies that have received magnesium sulfate from the mum.
Wanting to make a philosophical point.
As long as you don't want to beat me up anymore.
No, I think animal work is terribly important. Retrospective studies can be very interesting, but all of these need to be regarded as hypothesis generating. They pose a question that then needs to be answered in a proper randomised trial. And neonatology has got a very mixed track record of embracing early treatments that seem to make sense, seem to be good ideas at the time. Things like unrestricted oxygen for preterm babies. Great idea. Made them all pink, made them breathe more consistently. But then a year or two later, people found the epidemic of retinopathy of prematurity and blindness. Then a big swing back the other way. People said, oh no, this oxygen's terrible stuff. We'll take it away. We won't give oxygen. And another epidemic of cerebral palsy as we got it wrong in the other direction. Now, I think cooling is a very good example of where we've done it right. It's been done slowly in some ways, but very effectively and carefully. We've got a new treatment. It works in animals. We're going to try it in human beings. And over a period of a decade or a decade and a half, we now have a treatment that works. We know it works. We know that the benefits outweigh the side effects, but it's been done slowly and carefully. So I would think that anything new that comes along should be subject to the same amount of scrutiny. That includes postnatal magnesium. I think it's potentially there's some good, strong biological plausibility why it might work. Just to take a slight detour, there is very strong evidence now that antenatal magnesium is a good treatment. There are now 3 or 4 randomised trials, again, done carefully, done around the world. Antenatal magnesium sulfate given to women in threatened preterm labour reduces the risk of cerebral palsy. So tell your obstetricians, use magnesium sulfate antenatally. To use it postnatally, I think we should test it, as we should with all the potential cocktails, allopurinol, stem cells, xenon. They all need to be subjected to the same amount of scrutiny. They may be very effective, but they may also be harmful. So I think before the message from here shouldn't be to go on and go away and race out and try everything that you've heard here from any of us, but we flag the things that we're certain of. Cooling, great stuff. Roll it out. Do it in the prescribed manner. Other things, watch the literature. It's going to change, and I think Jerry's absolutely right. The next 5 or 10 years, the opportunities to treat with drugs for developing babies' brains is going to be enormous. So we're going to have to watch the literature, but wait for it to come out, I think, before we start throwing drugs around.
Well, I was about to say the same thing, but also with using hypothermia, I think it's very important to stick to the protocols that have been tested, because we only have evidence within these protocols that they work. And as both Jerry and Peter emphasized in their talks, we don't know what happens if we prolong cooling, if we decrease temperature and things like that. There's one question I'd like to ask Jerome concerning his talk, is hypocapnia. If we observe our patients clinically, a lot of them are admitted to the unit with severe acidosis, and these infants spontaneously are hypocapnic. So do we know what to do with those? Should we intubate and hypoventilate them, or what are we going to do? This is daily practice.
No, it is absolutely, and even in our rats, they do the same thing. If we put them under hypoxic circumstances, they hyperventilate and they become hypocapnic. So if I'm hearing everybody correctly, I think sort of the message from the animal data is oftentimes, raises opportunity, meaning here's something that looks like it works under these circumstances. I think what frequently happens when we try and transfer data from the animal to the human is that we don't actually transfer it in the way it's meant to be transferred. We take big brush strokes and apply it to everything. Certainly the adult world has done that when it's come to hypertensives or anything else. They use something in one circumstance and then whitewash everything with it, and sometimes you wind up throwing the baby out with the bathwater. In other words, you may get an effect, but under very strict circumstances. So the thing about humidity, just to clarify, because I got beat up over that one, was to really just raise an opportunity and a thought that we shouldn't be just throwing things at babies without thinking about how we're doing it. And when it comes to hypocapnia, I think it's the very same thing. I think there's some retrospective data that suggests that hypercapnia may provide some neuroprotection. There's some good animal data that suggests that it may as well. And now probably a clinical trial, or at least in the next little while, a clinical trial may be warranted where we allow babies to either under normal circumstances reach a more physiologic level of carbon dioxide, or under circumstances where they're intubated. I don't recall any of the data, or if there was any, looking in the hypothermia groups in the cooling trials, whether they looked specifically at carbon dioxide, because one might assume that they were.
Not sure. No, we did not. In our study, no.
I mean, that may be a simple way of looking just at the correlation between whatever the outcomes were and the carbon dioxide levels, because I'm sure all those babies had gases. So that would be one sort of way where it'd be worthwhile doing some preliminary work. But I think, so I think that to me, that's the message, is that we need to look very closely in a very strict circumstances at all of these aspects. A moral question, you can handle that one.
Obliged to treat every asphyxiated baby with cooling. Are there some babies that perhaps are so far gone that perhaps we should suggest to the parents that we do not offer this baby the treatment modality?
It's a very good question, and it's a question a couple of people have come up to me in the break. So thank you for asking it, and it's a very important one, and we'll be interested to hear everybody's opinion. Mine is to separate the cooling from the other question. If the question is, should we be actively treating this baby? And if on the balance of probabilities and with the agreement of the parents, the decision is no matter what we have to offer this baby, the outcome is so bad that for this family it's not the right thing to offer active therapy, then we don't offer active therapy, and that includes ventilation, and includes cooling and inotropes and whatever else we might throw at the baby. If, however, the decision is that we should be offering treatment, and the parents, knowing the risks, knowing that perhaps their baby has a 75% chance of dying or surviving with a major disability, and the decision that they make is, well, we'll take that chance, we'll look after our baby with cerebral palsy if that's the outcome, and that's what we'd like to do, then I think, yes, cooling is should be part of that spectrum, because whatever the chances are of this baby getting through in reasonable condition, they will be increased by cooling. Okay, so it might still be that the baby has only a 30% chance of emerging unscathed from its insult, but it will be better than if it had been offered nothing. So I think the decision is a broader one, that should we cool badly asphyxiated babies or not? It's should we treat those babies? And if we're going to treat, then yes, treat completely. But I'd be very interested in hearing what the others say.
I think the question is very well taken because from the clinical perspective, not only we have a window of opportunity to treat them with hypothermia, but we also have a window of opportunity to withdraw therapy or to withhold therapy, because some of these infants, after a couple of days on intensive care medicine, won't die immediately anymore. So if you have overcome the acute result of hypoxic ischemic encephalopathy with pulmonary hypertension, with failure of the systemic blood pressure, then eventually they will survive whatever you do, and then you have a severely handicapped baby. So you have to take that into consideration, I think, as well, together with the parents.
Yeah, I mean, it's a very good question, a very important one, and I think a very difficult one to answer for the reasons that were just laid out. And the only thing I would add to that is that when we discuss these issues with the parents, is that we, as best possible, try and do so with informed consent. And I don't, when I say that, I know we all do informed consent, but I mean almost full disclosure, because you're often, at least in my experience, dealing with parents who are obviously under very emotional circumstances and are looking forward to either ending a life being ended that they were very much looking forward to, or a prolonged life that they may not have the ability to envision for the next 20 or 30 years. And that's a very difficult conversation to have. I don't think we know all the answers because we don't have the biomarkers or the things that will tell us essentially whether that baby will die in the next 24 or 48 hours or go on to survive a better life. But to the best of our ability, I think the conversation has to be pretty complete. And you know, the simple answer to your question would be, I don't believe we should be treating everybody or absolutely everybody. I think we do need to look very carefully at the circumstances, particularly around those that are profoundly injured at the time of birth.
We had a case that might be informative just last week, a baby outborn, born with APGARs of 0.000, received, I think, 6 doses of adrenaline, and at about 25 minutes into the resuscitation, they decided to stop. Then 5 minutes later, of course, an experienced neonatologist would have seen this before. That the heart starts to beat and the baby starts to come good, and so at 30 minutes of life, the baby is alive, and it was then resuscitated. This is at a small peripheral hospital, cooled, brought to our hospital. For a baby like that, I think we would have no hesitation in saying the markers are so bad, we should be talking to these parents about not only not cooling this baby, but not continuing respiratory support, not continuing inotropes. And I think that's a fairly easy ethical decision or an ethical argument to have.
Except that we had a very, very similar baby in whom we terminated the resuscitation, and 5 minutes later the heart rate came back. This baby survived. Is extremely damaged with a gastrostomy. He's in an institution, but that's the case that led me to ask this.
Yeah, and it's
he survived without us doing anything.
Really, yeah.
Other than general supportive care.
Would the baby have survived if he was resuscitated in the case room? If he was not resuscitated in the case room?
The baby was basically born dead and resuscitated. Exactly the same story as Dr. Davis told.
Yeah.
There's always a few of those that haunt our careers, aren't there? And I'm not sure that there's an easy answer. Some babies we don't have the opportunity to withdraw care, and that sounds like your case. You did not. In our case, we did have the opportunity. We didn't, in fact, because the parents said, we know the risks and we want you to keep going. So, but I think our outcome is probably not going to be dissimilar to yours. Yeah.
We have this keep going problem all the time.
Yeah. There was a question this morning that we didn't get to
Yeah, it was about gas
And I
exchanges.
can't remember what it was. That was your question?
Yeah.
It was about gas exchange and hypothermia. Does it make any difference? Does it make any difference?
Well, during cooling, usually the total metabolism is reduced in the whole body. So you would expect that the oxygen requirements of all tissues is reduced, so also the CO2 production is reduced. And actually in our unit, we don't ventilate all infants on cooling at all, only a small proportion. So it will affect gas exchange, but probably also kind of protect the baby from exceeding metabolism.
I think it's largely a hypothetical question. Yes, you can get pulmonary edema as a result of cooling, but that's very, very, very uncommon. I think Andreas is right. Not only do they need less oxygen, they're making less CO2, so ventilation generally is not such a problem. The issue sometimes we see, and somebody else asked this question about pulmonary hypertension, important to distinguish between what happened in the trials that were designed 5 or 10 years ago and have excluded babies with severe pulmonary hypertension and now. And these days we are cooling babies and treating aggressively their pulmonary hypertension, as I think Andreas hinted at. So we would no longer consider an 80% oxygen requirement to be a contraindication to cooling. We would treat the pulmonary hypertension with nitric oxide and whatever else we needed to, and keep cooling, knowing that we can get through that pulmonary hypertension, and the benefits of cooling are now confirmed.
To ask for a discussion on at what time or what clinical stage should the decision on starting cooling be made. When we started cooling, we had EEG monitor as one of the criteria, but we omitted it after 1 or 2 cases where artifacts on the EEG led people to not cool babies that should have been cooled. So now we have purely clinical criterions. And I think we have to keep in mind in any case that time is brain, that we should start as early as possible. We don't have a 6-hour window. That's just an artificial thing from the protocols. 4 hours is better than 5. 5 is better than 6. 2 better than 3 probably. But you have a initially depressed child, which would then at some time improve. We have had a few cases where we think that cooling was probably not necessary, because what we saw was not a hypoxic ischemic encephalopathy, but initial depression, because the child wasn't through the acute episode. So could we find any recommendations on when should the decision be made? Fast enough, but not too fast.
People are pushing the microphone away, because that's a very good question. It's a very difficult question. The equation has changed a little bit with the demonstration of safety of cooling. So I think we're less worried about overdoing the cooling. But that being said, somebody else asked me a question. They were very worried because they hadn't cooled this baby who was a little bit depressed at birth, and went on to have a seizure at 24 hours. I don't think we can cool every baby with a tiniest hint of problems at birth. That being said, I think our attitude is we are more aggressive in cooling. We certainly don't wait for AEEG, and I think that was one of the messages of the ICE trial. You don't have to have that high-tech monitoring equipment to start. Most of these babies are born in little centres that barely have a blood gas analyzer, let alone an AEEG. So I think that's, as you say, more likely to mislead than to help. So I think if the baby fulfills those other criteria that we mentioned, the blood gas criteria, some clinical signs of encephalopathy, and a prolonged need for resuscitation, then we will cool. And I agree with you. The sooner the better. And if the baby fulfills those criteria at 90 minutes of age, we would cool, starting straight away.
We were just writing up the German guidelines for the implementation of hypothermia or treatment of hypoxic ischemic insults. And this was a big discussion, when to start cooling. And thanks to ICE trial, which started cooling the earliest of all other trials as compared to, I think it's feasible to suggest that active cooling should definitely not be initiated in an infant that is suspicious for hypoxic ischemic encephalopathy. Sometimes the clinical sonar scores can only be decided over hours. So the blood gases, the APGAR scores, and the need for resuscitation are probably the entry criteria nowadays to not actively warm babies already in the delivery room, I would say, and then proceed to cooling thereafter.
Yeah, I would agree. I think the only addition I would have there is that one would not want to wait too long, because, as you point out, brain is time and time is brain. So the longer one waits beyond meeting substantive clinical criteria, it would not be warranted. And given the lack of adverse effects of hypothermia, it would be, I think, prudent to start as early as you can. And certainly in the preclinical data, in the animal data, waiting longer than that so-called 6-hour window, albeit artificial, has not been shown to be beneficial. So the earlier you can start being satisfied that pHs and APGAR scores, etc., are within the criteria for cooling, I would go ahead. Does that make some sense? Or you look like you're not quite satisfied.
I am not quite satisfied. I think when we look at the ICE trial, I think you approached a little more than 500. And I think that would be on the asphyxia criteria, and you included around 220. And I suppose many of those that were not included was because they had an asphyctic insult, but that they had none or very slight signs of ischemia. And they would have to be in your situation, probably have long transport with suboptimal care of all the other things, blood pressure monitoring, glucose monitoring, whatever, including also the increased burden for the family of a lung transfer. So probably those that have no encephalopathy but only short asphyxia will not benefit from cooling. So I question a little whether we should start omitting the neurological criteria for cooling.
But, I mean, we know from the follow-up of the mildly affected infants that they have a pretty good prognosis. So we should probably do another trial and have much less strict criteria to enroll infants to hypothermia and look at long-term outcome.
Yeah.
But we don't have these data available as far as I'm aware of.
Yeah, I think that one of the things that is that the kids who sort of were in the mild category are not really followed, and what I'm aware of is that long-term follow-up, like up to preschool and beyond, some of these kids do have some degree of learning disability and developmental challenges or school readiness that is, is not benign. The other question is how strict adherence one should be. So if you have an acute asphyxial event whereby the baby's APGAR scores are a bit low or has a mild neonatal encephalopathy early on, but maybe they don't meet the cord gas criteria or the cord gas pHs. So it's possible that some of the exclusion in the ICE trial, and I don't know the answer, were related to them meeting the clinical criteria, and they never had the cord gas criteria, so they may have, is that, because they were only...
I think most of them were the clinical criteria, and you're right, it was the milder babies.
So they just bounced right back after birth, and perhaps by the time they got to the unit didn't meet the criteria.
I haven't heard that there's a trial planned, and technically that's going to be a very difficult trial to run because it's probably going to need thousands of babies because the burden of illness is so small, or we think it's small, and to detect an improvement in cooling mild babies is probably going to be needing to follow them out to 5 or 6 years. So you can understand why researchers are less keen to take that question on than the easy one, or the relatively easy one. Take the group babies on average with a pH of 6.9 and see if your treatment works. But it's a good question, and it's a natural question that follows most treatments in neonatology. It works in this group. Can we use it in a broader group? And the answer is we don't know, I guess, is the answer to your question.
Just one more question about some practical point of a hypothermia protocol. I'm concerned about the ventilation. So do you treat a patient on CPAP or BPAP or whatever? And if so, how you deal with sedation, or do you have some sedation, because we know that hypothermia causes pain, probably. So how to deal with it, and maybe you add some practical point about the new, up-to-date information according to the ventilation. Thank you.
We do a hypothermia like we did in the European trial. So all infants on hypothermia receive morphine as a sedative because it's not pleasant to be cold. We know that. And with regard to ventilatory support, we would adjust that to the needs of the baby. So if the baby does not sufficiently breathe, we would go for a respiratory support non-invasively or invasively. So I'd like to add and kind of go further to my last talk tonight, is that we actually do adjust the humidification temperature of the ventilator if we use it to 34 degrees, which you don't do in Melbourne, and we'll come to that later today.
So I agree with everything Andreas has said. Although we don't use morphine routinely, we've got a very low threshold for using it. And once you've started, you just judge the baby on its merits. It gets whatever respiratory support it needs. Some babies will need no respiratory support, others CPAP, others on the ventilator for the full 3 days. But those are the minority of cooled babies in our hands. Most of our babies are on either just air or a little bit of CPAP.
The point was that we, during our protocol, we use the morphine as well, so it's hard to start the non-invasive ventilation after it without any side effect and without delay the intubation, because probably after morphine can affect the spontaneous breathing. That was the point. And what was the difference without, according to the mechanical ventilation, non-invasive ventilation, patient, group of patient during the hypothermia? Does it affect it or not? That was the point, actually.
Well, if I understand correctly, it is possible to manage babies on morphine on non-invasive ventilation.
Probably not. That's why I ask you, because we do not have any patient on the support non-invasive ventilation. That's why I ask you if it's possible or not.
It is possible. I wonder what doses of morphine you're using.
10.
Yeah. Okay. That's what we would use. Yeah.
Yeah. Exactly the same. Yeah.
Are there any other questions? And enjoy your lunch.
Thank you very much.
Thank you very much.